Hello, everyone, and good afternoon. Thank you for joining our session today, our community conversation. Let's talk about health. Today's topic is heart health. February is Heart Month in more ways than one. I'm Donna Jacobs, Senior Vice President at the University of Maryland Medical System, and I will serve as your moderator today. Our Let's Talk community conversations are designed to do four things: increase awareness about important health issues, provide important health information to people in the communities we serve in a clear and concise way, improve communication between patients and healthcare providers, and help patients and families get the information they need to maintain and/or improve their health. Leading our conversation today is Dr. Matthew Peters. Dr. Peters is a board-certified cardiologist who practices at the University of Maryland St. Joseph's Hospital. He has advanced training in cardiovascular disease, and his practice includes identification and treatment of a full range of heart conditions, ranging from high blood pressure, high cholesterol, to congestive heart failure and disease of the heart, as well as everything in between. As participants in this conversation today, you have an opportunity to ask questions of Dr. Peters. Feel free, if you choose, to post your questions in the Q&A box as Dr. Peters is speaking, and we'll be happy to address as many questions as time will allow. Should we run out of time, your questions will be collected and answers will be posted on our website at a later point, and more on that to come. As well, you should know Dr. Peters' slides will be available to you following today's conversation. And finally, let me say that the information that is shared today is meant to be for general knowledge and information. It's not meant to be specific information related to an individual's health concerns. And with that, Dr. Peters, let's get us started.
All right, well, thank you very much, Donna, for the introduction, and thanks everybody for attending today. Basically, what I want to do is talk you guys through some of the general basics of cardiology, some of the different types of heart disease, some of the ways to diagnose and recognize signs of heart disease, and some of the different treatments for heart disease and what can be done about it. One theme that will be reoccurring throughout the lecture is this Ask Me 3 series, where basically with each sort of sub-subject, we'll address what is the main problem for a patient, what needs to be done about it, and then why it's important to do that. So first, what is heart disease? I think heart disease is something that's thrown around a lot, and there's some confusion about what actually heart disease means. Typically, when we think about heart disease, we think about heart attacks or blockages in the arteries. But heart disease actually spans much larger than just blockages. The way I often explain heart disease to my patients is to think of the heart as a house. And the first part of that is the overall structure or architecture of the heart. And these are our heart valve diseases and heart failure. So with this, we look at the overall structure of the heart, the size of the heart, the thickness of the walls of the heart, and the heart valve, which can be seen over here, sort of recognize doors that allow blood to flow from one chamber of the heart to the next. So when we think about the heart, we first think about the overall architecture, and it pertains to the function as it relates to heart failure, and then as it relates to this particular heart valve. Coronary artery disease is what is typically thought of when we bring up heart disease. This really relates to the plumbing of the heart. There are coronary arteries, which are the blood vessels that supply blood flow to the heart. And over time, just like the pipes in a house can become clogged, these arteries become clogged with plaque and fat, and that's what causes the heart attack. So just like your pipes normally will have a nice open diameter, allowing water to flow through, over time they can become clogged. And as this diameter sort of narrows and the pipes become more and more clogged, this can cause chest pain, can cause shortness of breath, and can ultimately cause a heart attack. And then the last part of heart disease, which I think is also important to mention, is the electrical abnormality. Just like your house has electrical wiring, arrhythmias or abnormal heart rhythms represent a dysfunction of the electrical circuit of the heart. I think the most common manifestation of this is atrial fibrillation, which becomes very common. I'm sure a lot of you guys have heard of, which represents one abnormality of the heart. And I'm sure many of you know people who have pacemakers or defibrillators. pacemaker is something that treats a heart rate that's too slow, so basically the electrical conduction system is too slow. And the defibrillator treats a heart rhythm which is too fast. And basically, when the wire in the heart just allows conduction to spread too quickly through the heart. So what are the symptoms of heart disease? And this really varies. This bases off of what type of heart disease we're talking about. Just like we talked about previously with coronary artery disease and heart attacks being the most common in terms of what the general population hears about, we think about chest pain. So patients who are having a heart attack or have a blockage in the heart, we worry about chest pain. But there's some other symptoms that can manifest with that as well. This can be shortness of breath. This can be decreased exercise tolerance, where you find yourself not being able to walk as far as you could previously, or not be able to do activities that you were previously, or sometimes even dizziness or lightheadedness. Heart failure, which we just talked about, represents a dysfunction of the heart's pumping ability. And this can cause a couple things. Shortness of breath is often the most frequently encountered symptom, where basically the heart's ability to pump is not sufficient to supply blood flow to the body as it needs it. Another thing you can see with heart failure is weight gain or lower extremity swelling. And again, if you think of the heart failure as a pump, just like you have a sump pump in your basement, basically if that pump starts to fail, fluid will start to accumulate. And just like you would with your basement, fluid can often accumulate from the bottom up. So you can see this going in the legs, the thighs, the stomach. And then over time, depending on the type of heart failure or the exact severity of heart failure, this can cause fluid to accumulate in the lungs and other parts of the body over time. Now, arrhythmia, again, this is that electrical abnormality we saw in the heart. And this is, like we talked about before, patients who need a pacemaker or defibrillator or have atrial fibrillation. And with these conditions, we typically can see symptoms of palpitations, an abnormal heartbeat that you feel, like a fluttering sensation. This can represent dizziness or lightheadedness, people who've passed out in the past, or sometimes people just can take their own pulse and notice an irregularity there. And this can be a sign of an electrical abnormality of the heart, which again we refer to as arrhythmia. So the first Ask Me 3 question that we want to go over is if we have a patient come in and say, I'm starting to feel out of breath when I walk, to get the mail, and sometimes my chest hurts. Like we just talked about, shortness of breath can be a sign of either heart failure or it can be a sign of a coronary artery disease, a blockage in the heart, or an early symptom of a heart attack. So that's really the main problem. If this represents a big change for you, this would potentially constitute an emergency. A heart attack is an emergency, and we do have treatments that can be done if caught early. So if the symptoms are significant and continue to get worse and don't really go away, we typically recommend that these patients call 911 or an ambulance to get emergency evaluation in the emergency room. And why is it important to do this? Like I just said, we do have interventions that we can do for heart attacks. So patients who have a blockage, the longer the blood flow is decreased that part of the heart, which is a muscle, can start to weaken and can scar over time. So we like to say time is muscle, where basically the longer it takes to restore blood flow, restore oxygen supply, the more damage can occur to the heart. And there is overlap before we talk about the structure and the electrical and plumbing of the heart. But over time, a plumbing issue where there's a clog can cause decreased blood flow, and it can cause weakening of the heart, and can eventually cause the heart failure. So a heart attack not only can cause a problem immediately, but if the blood flow is not restored quick enough, over time this can cause heart failure and some other problems. So again, if it's a change in symptoms that's significant, not going away, I think it's important to get evaluated immediately. And that's really because we have interventions that can be done quickly that can not only improve symptoms, but can potentially be life-saving. So who gets heart disease? So heart disease, at least prior to coronavirus, was the #1 cause of death in the United States every year. Last year was a close #2, and I would anticipate that it'll be back to #1 over the course of the next year. But we basically see 655,000 deaths per year in the U.S. This accounts for a total of about a quarter of the deaths we see in the country. And we see about 365,000 of these deaths, a little bit more, due to the coronary artery disease, for the heart attack, the blocks in the heart specifically. This affects 7% of the population greater than 20 years old, which is a pretty significant portion of the population. And it's not just older people, but we actually see 20% of the deaths are in patients who are younger than 65. So heart attacks and heart disease in general is not just something of the older population, but we see patients, I have patients in their 30s who've had heart attacks. And obviously it gets more frequent as you get older, but it's not something you can write off completely just because you're a little bit younger. Now, in the U.S., we see about 805,000 heart attacks per year. And again, a lot of these are not repeat offenders, but about 80% of these patients, 75 to 80% of these patients are patients who have their first heart attack per year. So a large percentage are not patients who have known heart disease previously. This is a quick map on the right, which just shows heart disease and where it's most common throughout the country. These are men aged greater than 35 on the top and women aged greater than 35 on the bottom. And it's both interesting to see. So the redder areas are areas with more frequent heart disease, where we see higher heart disease deaths. And as we get into talking about some of the risk factors shortly, you'll see this will correlate with countries where there's also higher rates for obesity and lower rates of exercise and probably worse diets. A lot of that's in the deep south. As you get into the West Coast and some of the other more rural states, we see a little bit of a drop-off. But we'll come back to that as we talk about risk factors shortly. So risk factors for heart disease. There's multiple risk factors. High blood pressure is certainly a common one. This is something that's easy to check both at home as well as in the doctor's office. High cholesterol is important to identify because we have very effective medications to lower cholesterol and reduce risk. Smoking is a very important reversible risk factor. Thankfully, the smoking rates have declined in the past couple of decades, so it continues to put you at very, very high risk for heart disease. Diabetes certainly puts you at high risk. Both being overweight is a major risk factor, and this sort of ties in with the next one, which is lack of activity. Excess alcohol intake can also be a major risk factor. And in family history, so patients who've had parents or first-degree relatives with a history of heart disease. And with this, I think it's important to point out that in order to really consider something a significant family history, we typically look for patients who've had heart problems below the age of 60 or 65. As people get older, into their 80s and 90s, it's not uncommon to have heart problems. And in this case, I wouldn't really consider that a significant family history, but rather just sort of a product of getting a little bit older and developing that increased risk as you get older. So how to prevent heart disease? Obviously, there's a lot of things we can't change. Our genetics are a big risk factor that we cannot do anything about. But we obviously want to focus on things we can do. Obviously, smoking cessation is a very important one, which should go without saying. But diet is a very, very important modifiable risk factor. Obviously, we know we want to limit alcohol, but other things we can do, just from a general day-to-day standpoint, are trying to avoid any types of really fatty foods, saturated fat, trans fat, just a lot of the red meats and a lot of the baked goods with lots of butter and oil in them. Increasing fiber intake can actually be very beneficial for helping cholesterol and decreasing plaque buildup. Lowering the salt intake is very, very important. We recommend less than 2 grams of salt per day. That's because salt intake is a very, very high risk factor for high blood pressure. Basically, the body fluid will follow salt, so the more salt you intake, the more fluid is pulled into the blood vessels, and this serves to raise the blood pressure significantly. Lowering sugar intake is very, very important because it's the risk factor for diabetes, which we just saw as a major risk factor for heart disease. And what I tell all my patients is that you have to be very careful when you go out to dinner because they often add a lot of extra salt and sugar in the food to make it taste good, to make customers come back. And what else comes when they go to the grocery store, you should really be able to accomplish most of your grocery shopping by doing a lap around the periphery of the grocery store. So if you think about when you walk in, you have the produce section, the dairy section, there's a deli and a seafood area, and then sort of a baked good. And not only does it make for a more efficient trip to the grocery store, but I think a healthier trip to the grocery store. A lot of those middle aisles where you see a lot of additives with a lot of extra sodium and a lot of extra preservatives, a lot of extra sugar. So you should really try and avoid those middle aisles as much as possible. And I think you'll find this will lead to a healthier diet and also a quicker and more efficient trip to the grocery store than Arizona. And then for exercise, the American Heart Association recommends about 2.5 hours of moderate intensity exercise per week. Typically think about doing 5 days of 30 minutes per week. And this doesn't need to be, going out and running 3 or 4 miles, but just a moderate intensity walking or biking. Obviously, it's more difficult this time of year, but anything you can do, the more that you can get the heart rate up and just get yourself active and less sedentary makes a big, big difference as far as preventing heart disease. So our next Ask Free question is, when a patient comes in, my weight has been increasing every year along with my blood pressure. I don't have the time or energy to exercise. So first of all, what's the problem with it? High blood pressure is a major risk factor for heart disease. It's certainly a risk factor for blockages in the arteries, the coronary artery disease, and can lead to increased risk for heart attack. And on top of that, it's a big risk for congestive heart failure also. The heart's a muscle and doesn't like to have to work harder than it needs to. And when the heart is basically pumping blood out and does it against higher pressure, as you would see with patients with high blood pressure, the heart over time can start to weaken. And this is sort of a sign of the heart potentially developing heart failure, either from a stiffness of the heart or from a general weakening of the heart. So blood pressure, while often not where we have it, is a major risk factor, especially for heart disease. So what do I need to do? Make changes to your diet. As we just talked about, a lot of those food items you can find around the outside of the grocery store. So as many fruits and vegetables as possible. Whole grains are much better than white bread or that type of product. Lean protein sources, so chicken and pork and white meat are generally better than the red meat. And trying to avoid soda, sugar, and sweets with just extra sugar that we don't need. And as we talked about, the 2.5 hours of activity per week. And again, you want to build up slowly. The key is not overdoing it, but sort of just build up that exercise tolerance over time and make it something that's sustainable. A lot of my patients who are concerned about not being able to exercise too aggressive, I tell them, this is for the long run. I mean, a lot of patients who are really aggressive exercising when they're younger, marathon runners, that type of thing, well, that's helpful. The key is being able to do something in your 70s, 80s, and 90s. So you don't want to overdo it and make knee problems or ankle problems or that type of thing. But really have something you can prolong over a long period of time. It's more important to be able to have moderate exercise later in life than it is to have exercise really, really hard when you're a little bit younger. And then why it's important for me to do this, to improve your diet, not only to prevent heart disease, but to lower your blood pressure. I think you'll sort of find a snowball effect where the more you exercise, the more energy you get. And the easier it is to do other things. So the sort of, you can break through that initial barrier, it gets easier over time. So diagnosing heart disease. So, we talked about what heart disease is. We talked about a lot of risk factors for heart disease. The question now is sort of what do you want to do as far as how to recognize different things, reasons to go to the doctor, and what we can sort of identify in an office-based setting. Obviously, you always want to try to avoid going to the ER, having to have to stay in the hospital. So coming to the office, a couple things we can do. Most of our patients we see the first time, we get an EKG. An EKG can tell us a lot of things. The biggest thing it shows us is the electrical rhythm of the heart. So we can pick up conditions like atrial fibrillation, and we can pick up slow heart rates, fast heart rates. We can also sometimes see signs for previous heart attacks. We can see signs of the heart wall being thickened or the heart being enlarged. This is a very, very easy thing to do. That's a good screening process. Takes less than a couple minutes. It's just of having a couple stickers on the chest, and then you can immediately get a printout like this in the office while you're there. So an echocardiogram is another thing that we can also do in the office. An echocardiogram is an ultrasound. It's literally the exact same type of technology as a pregnancy ultrasound. We do this in the office here in cardiology offices all over the country. Basically, as a patient, you're just laying there and you have an ultrasound tech with a little bit of gel on the chest. It can immediately get pictures of the heart. And the detail of which we can get is actually pretty phenomenal. We can see instantly how well the heart's functioning, how well the heart wall muscles are squeezing, so we can diagnose heart failure. We can measure the size of the heart and the thickness of the heart wall. And we can also see very, very well the heart valve. So if there's a valve issue where the valve is too tight to allow blood flow, or the valve is too leaky, we can immediately see this and identify this within a 15 to 20 minute test that can be done in an office-based setting. So a lot of information can immediately get from that. Coronary catheterization, we don't do in the office, but we do certainly do on outpatient setting, meaning patients who are not admitted to the hospital. And this is where we look for patients with plumbing issues in the heart. And basically what you do is have a chest X-ray machine that comes down on top of the patient and injects some dye and allows the dye to track through the arteries, and you can look for a blockage. And this has become a very, very routine procedure. It can typically be done in 20 to 40 minutes. And at the same time, there's also the capability to put a stent in to restore blood flow and allow the blood to come back immediately. In many cases, the patients go home the same day. And even if it's more complicated procedures, patients still go home the next day. It's something that's become very, very easy to do and really minimal time commitment and doesn't have a big impact on the patient's day-to-day life. So a heart monitor sort of expands what we talked about earlier, the EKG. The EKG shows us a lot of information about the electrical activity. Now, a lot of patients who have symptoms of dizziness or lightheadedness or palpitations, obviously the symptoms are sporadic, and there's a very, very low likelihood of capturing those symptoms during the 6 seconds we're doing EKG in the office. So a heart monitor is something that you can actually wear and gives you a continuous EKG at home. There's some technology with the iPhone now where you can get some information like this. This is the same basic concept that gives you a little bit more detail. And there's 2 major benefits to this. One, it surveys every single heartbeat you have. So if there's any type of abnormalities, just to pick it up. And 2, there's also a function where there's a button you can push. So if you're having the symptoms, you can push the button and sort of bookmark what's going on. And then we are able to hone in and say, well, this is the symptoms you're having, this is what your heart rhythm was doing at that time. And we can make conclusions about whether or not the heart rhythm is actually causing symptoms or not. So you see the picture here. The heart monitors have become very, very easy to use. Before, there were wires hooked up, attached to the belt. It was not something easy to use. Now they're literally just stick on things on the chest that you can shower with, you can sleep with, and some you can take off. And most of the year, you wouldn't even know that they were there. There we go to the next slide here. And then one of the benefits of being able to do that heart rhythm monitoring is to determine patients who would potentially need a pacemaker or a defibrillator. Like we talked about before, the pacemaker is for heart rates that are too slow, where basically if a heart rate is not triggered on its own, the pacemaker will send a low electrical impulse that will trigger the heart to beat and prevent patients who might be passing out from a slow heart rate or from an irregular heart rate. And the defibrillator is the same exact concept. It does everything a pacemaker does, but also treats heart rhythms that are too fast. So if it picks up a heart rhythm that's very, very fast, it's potentially dangerous. It delivers a little shock to the heart and shocks the heart back to normal rhythm. As you can see here, these are very, very small devices. They're implanted just underneath the chest wall. And these last a very long time. The wires that are put into the heart are usually good for your entire life. And this little metal box is a battery that lasts for about 12 years. After that, it's a very simple procedure just to change the batteries out. Same concept of changing the batteries in your TV remote. And then should get another 10 to 12 years after that. And, these are very, very effective therapies. And also another one that can be done with very minimal hospital stays. We typically bring patients in, they have the procedure done in the afternoon, and they're home by lunch the next day. So for preventing heart disease, we've talked about a little bit. In addition to diet and exercise, there's several things we can do in the cardiology office that can help identify heart disease and lead to prevention of heart disease. One is just getting a blood pressure read. I think it's very helpful to just get a good idea about where your blood pressure is. And one thing that I think is important for patients is that you don't just check it when you come to the doctor's office, but also check it at home. Many times we see blood pressure more high in the office than you would at home due to a combination of factors. Often patients are rushing to get to the office, they're a little bit nervous, having not been there before. So I do encourage patients to check it at home. But one benefit of checking the blood pressure in the office is you can actually bring your blood pressure cuff from home, whatever you're using at home, and we can do a side-by-side comparison and make sure that the cuff you're using at home is actually accurate and seems to be a good representation. And then once we establish that, I allow my patients check their blood pressure a couple times per week and just keep everything in a book or a log, and then we can review that when you come to the office. And as opposed to just changing medications based off of one time in the office, we have weeks, if not months, of data to look at. So we can do in the office is some general blood work. We can give us a lot of information about kidney function, liver function, cholesterol, very, very important, something that can be easily checked and give you results in about 12 to 24 hours and can really guide therapy and prevention going forward. So next, ask me 3 questions. Is a patient who says my father and grandfather both had high cholesterol, and my blood work shows my cholesterol increased from 5 years ago. So what is the problem? So as we talked about a lot, family history is a major contributing factor for a lot of health problems, and especially with cholesterol. What do I need to do? Having annual physical, depending on where the cholesterol is, check in once a year helps identify changes and trends and determine whether or not it's something we can address with dietary modifications or if something might qualify for medical therapy. And why is it important to do this? As we talked about, high cholesterol is a major risk factor for heart disease. And something that's very, very easily treatable. So it's something we can identify that can have enormous downstream benefit as far as preventing complications down the road. So a couple of resources I'd like to turn your attention to. The first is a resource for University of Maryland St. Joseph's Medical Center, the Heart Center. So we're located in Towson, right next to Towson University. The outpatient office is connected to the hospital, so we have a lot of resources as far as what we can do in the office, and this will give you some information about phone number, contact information, exactly what those resources are. The American Heart Association has a lot of recommendations regarding diet and exercise and many of the preventative topics that we talked about. National Heart, Lung, and Blood Institute is an NIH sponsored institute that, again, has a lot of information about awareness and education and preventative measures. And then this CDC is also another good resource. It just has lots and lots of good resources about warning signs, risk factors, and what you can do to sort of minimize your chances of having heart disease going forward. And if you are diagnosed with heart disease, how best to handle and treat it.
Dr. Peters, thank you. That's excellent. There are a few questions. There are a few questions that have come in, and I'd like to try the two of them together, if I might, because I think they're reasonably related. The first one, it says, how important is it that we be screened? I have no history of heart disease, and how do I get screened? That's one question. And then there's a second question that I think is sufficiently related. So it says, I recently had a heart attack with 100% occlusion, no risk factors other than stress. Is there a way to be proactive in testing one's systems? All of my EKGs were normal over time.
Sure, yeah, both great questions. You know, I think from a sort of fundamental level, the biggest thing is having your blood pressure and cholesterol checked routinely. Those are the two biggest modifiable risk factors, both of which typically don't have any symptoms, and both of which have very, very effective treatment. So that can be accomplished either in a cardiology office or a primary care office. And that can allow us to sort of reverse stratify you and sort of place you as far as how close we need to monitor you, whether or not you need to be treating medication, and just sort of what the plan is going forward. Obviously, there's always the patients that don't have any risk factors whatsoever, and those are unpredictable. And besides just having, you know, routine appointments with your primary care doctor to sort of look out for warning signs and blood pressure and cholesterol, we don't typically recommend screening tests with stress tests or EKGs or anything like that, just because a lot of heart disease is truly symptomatic, and it's just, you know, you can sometimes turn up things you're not necessarily looking for, not necessarily wanting to see, and can lead to a lot of unnecessary things down the road. So I think from a general population without risk factors, blood pressure and cholesterol is very, very important. And outside of that, it should be more of a symptom-based approach or a symptom approach or a diagnostic approach really customized to you based off your other risk factors.
Great. There are a couple of questions that I'll call are they the same or different? The first one is arrhythmia the same as an irregular heartbeat?
It is. Arrhythmia basically means abnormal heart rhythm. So an irregular heartbeat is when you feel your pulse, you feel some irregularity, and that is typically due to an arrhythmia. And there's arrhythmias that are more serious, like atrial fibrillation, which increases your stroke risk, and there's arrhythmias which are less serious, which is the extra beats here and there. So arrhythmia is a very, very broad term for electrical abnormalities of the heart. Many of them are very benign, don't have any cause for concern, and some are more serious.
And a second, are they the same or different? Is the heart monitor that you mentioned the same as a Holter monitor?
The heart monitor is the same as the Holter monitor. Basically, the two terms are used interchangeably, and they basically just allow us to monitor the heart rhythm in an outpatient setting.
Okay. One more, are they the same or different? You spoke about 2.5 hours of exercise per week. What about the weekend warrior? Person says some people are really busy. The weekend warrior who does, 4 hours on a Saturday and 4 hours on a Sunday, but much less or none during the week. Is that the same ultimately, or is that different?
It's a good question. I mean, I think, any activity is good activity. So if you only have time on the weekend, that's absolutely fantastic. I think in an ideal setting, it would be a little bit more moderated, spread out over the course of the week. But again, any activity is better than none. And if you're getting to 2.5 hours on the weekend, that's all you can do. That's still fantastic. But in general, I think the more frequent you can do it, if you can do some activity on a daily basis or 5 or 6 days a week, that's better than 1 or 2 days. But again, you take what you can get. Everybody has different schedules. This time of year in Baltimore, you're limited as far as what you can do exercise, as far as going outside. So I think it's just, anytime you have an opportunity to do what you can, to take advantage of it.
Great, very informative. Thank you. All right, another question. I have swollen legs and take 60 milligrams of Lasix a day. I think my cardiologist has done many tests and said my heart is fine. What might be other causes of this fluid retention?
Yes, that's another good question. I mean, with swelling the legs, there's a couple things that come to mind. We always want to rule out a heart valve issue or weakness of the heart first. A blood clot in the legs can certainly cause swelling. Often that's more likely to be on one side as opposed to both sides. It's possible you have blood clots in both legs, but that's less likely. Usually we worry about blood clots more with one leg than 2 legs. Kidney conditions and liver conditions can sometimes cause swelling in the legs. Those can be evaluated very easily with standard blood work in the urine sample. And sometimes it just represent an abnormality of the veins in the legs, where the veins are a little bit less effective and efficient in returning blood to the heart. And it's that primary issue that can cause the swelling there.
Okay. My heart flutters fairly frequently and leaves me feeling lightheaded or dizzy. Is this normal?
So I think that for some people it is normal, for some people it's not normal. And that's the type of patients where we recommend getting a little bit of a workup. I think this would certainly be with an EKG in the office. And depending how frequently the symptoms are occurring, probably that's somebody who would benefit from wearing a heart monitor in an outpatient setting. And it's really crucial to be able to document what is going on with the heart electrically when those symptoms are occurring. And sometimes we find there's no relationship at all. And sometimes we're seeing that people are sensitive to certain heartbeats that are not dangerous. And sometimes we see heart rhythms that are a little more dangerous. So I think that's the perfect type of patient who would benefit from a heart monitor, especially one that we can monitor and that they can keep a diary and press a button that shows they're having symptoms. And we can really isolate exactly what's going on with the heart when those symptoms are occurring to see if there's a relationship or not.
All right, another question. What is little a, and that's in quotes, little a? My sister told me she has that and that every member of our family should be tested for it, but I don't know what it is.
What was little a?
Little a and the letter A.
Yeah, so little a is basically refers to a subparticle group of cholesterol. Typically when we get cholesterol checked for 3 big things. One is the LDL, which is the typical bad cholesterol, which you want to be low. Number 2 is the HDL, which is the good cholesterol, which you want to be high. And then triglycerides is the third one, which is a big fatty particle, which you also want to be low. Now, within the last 4 to 5 years, so from a mainstream standpoint, and for probably 20 years from a research standpoint, we've been able to actually look at these particles that make up the cholesterol with more detail. And little a is one of those particles that puts patients at high risk. So somebody who even has normal good cholesterol and normal bad cholesterol, that'll sometimes mask these particles that put you at higher risk. So I think anybody who has some risk factors for heart disease, it's warranted at least a one-time look at this to make sure that we're not missing anything that would not be reflected in a normal cholesterol panel. So basically a little bit more detail than your normal cholesterol panel.
One of our viewers said, I'm looking for or thinking about looking for a cardiologist. How do I choose? What are the factors I should be looking for when picking someone for the first time?
Yes, that's definitely a good question. I think that, it's always good to ask around and, family members or friends who've seen a cardiologist. I think that a peer recommendation is probably the most important thing because many reviews, as you read on the computer or in the magazine, I think knowing somebody has a good relationship with a cardiologist is always very, very important. So I think that's very, very, that's probably number one most important thing. Number 2, different cardiologists have different specialties. Some people specialize in coronary artery disease. Some people specialize in electrical abnormalities. So I think if you have a specific issue, you want to try and correlate that with what you're seeing in. Or if it's somebody who's more general, the focus is on prevention. And I think it's also important, location is important. Cardiologists are a little bit like primary care doctors. A lot of my patients I see every 6 months, every year. So I think you want to make sure it's somebody that, that's easy to get to and convenient. So if you need to go in, you can do it on a whim or, make it something that's doable for the long haul.
Here's a term that I've not heard before. We've got some really informed viewers out there.
Yeah.
This person says, age 75, and I've been on blood thinner since 2003. I'm wondering about having a Watchman installed. I guess that means a pacemaker or defibrillator.
So Watchman procedure is another newer procedure that we've done. And basically patients with atrial fibrillation are at a higher risk of stroke. And to sort of modify that risk of stroke, we traditionally have people on blood thinners to decrease that. Now, the patients with atrial fibrillation, if they were to form a stroke, it comes from a blood clot in the heart. And often occurs from a chamber of the heart called the left atrium. And there's a little part of the left atrium that hangs off of it called the left atrial appendage. And the risk of this with stroke, this is where basically stroke originates from. And the reason for that is that this area of the heart does not communicate well with the rest of the heart. So this is where clots can form. And a Watchman procedure is something where you can basically go in and prevent blood clots that would form here from getting out to the heart and getting out and causing stroke. The benefit of this is that this is done successfully. This can potentially get rid of your need for a blood thinner long term. Now, blood thinners, while they are typically tolerated very well, they do thin the blood, so they're going to increase your risk of bleeding. So it's a medication that you don't need. It's a medication that's nice not to be on. So the Watchman procedure is something that can be done. It can decrease your risk of stroke and can alleviate that potential need for blood thinner long term.
Reasonably similar question. I had a pacemaker implanted in my mid-50s. Does a pacemaker shorten my lifespan?
No. In fact, it actually really does the opposite. Pacemakers and defibrillators are going to prevent abnormal heart rhythms that could potentially cause you to pass out or could potentially cause sudden cardiac death. So that's why they're put in, is they're put in to increase survival. Now, if you want to compare somebody with a pacemaker to somebody without a pacemaker who had no heart issues, it does not shorten your life. Pacemaker by itself does not really have any effect on the longevity of your life whatsoever. There is a very small risk of infection around the time the pacemaker is put in. But after that, there's no long-term complications that have any impact on your length of life or even your quality of life really going forward.
Okay. Here, sophisticated listeners.
Yeah.
Can a left bundle branch be reversed? I don't know what a left bundle branch is. So I have to start there.
Yeah, so a left bundle branch block, basically the heart has an electrical conduction system that allows or electrical signal to travel from the top part of the heart to the bottom part of the heart. And the left bundle is one of two bundles, the other being the right bundle, that basically serves as the highway for electrical conduction between the top part and the bottom part. And it basically means the left side of that conduction system is going a little bit slower than the right side of the conduction system. It cannot be reversed, but usually does not cause problems long term. If there's a right and a left bundle branch block, this would be called complete heart block, and that would be a potential indication for a pacemaker. But the left bundle branch block is not reversible, but also does not typically cause problems. The other thing that I think is important to recognize about left bundle branch block is it changes the appearance of your EKG a little bit and can sometimes make it more difficult to recognize heart attacks. So I think if you have a left bundle branch block, this is something very important to let your doctor, or if you ever go to the ER, know that you had that previously, because that can affect their interpretation of the EKG and can sometimes make you think you're having a heart attack when you're not. And then I think what's also helpful is patients who have left bundle branch block or any EKG in general. I think it's helpful to get a copy of your EKG from your doctor. We're happy in our office always to make sort of wallet-sized laminated EKGs you can carry in your wallet. Your EKG is kind of like your fingerprint. So I think if you can take an EKG and you go and you say you have chest pain one day or something else, and you can walk in there and sort of present what your previous EKG looked like, that's very, very helpful. So I think if you have a left bundle branch block, it's important to recognize that and tell providers. And then, like I said, for anybody with any type of EKG, I think it's helpful to have a copy of it. And if we can if you can come to our office, we can make you a copy that you can put in your wallet. That's even more helpful. It provides tremendous information going forward.
In the few minutes that we have remaining, I'm just going to try to select the questions that have the broadest import, if you will. So one says, there was a slide earlier that listed risk factors. Were they listed in order? Or maybe, since we won't go back right now, can you sort of list in order the risk factors that people should be aware of?
Right. So a lot of the risk factors are pretty comparable as far as where they, fall on the list. High blood pressure, high cholesterol, diabetes, smoking are all pretty similar. I would have to look up exactly how they rank and what the percentages are. But the bottom line is that they're all so high that they all need to be treated equally. One risk factor that falls a little bit lower that I did not include in that list, but is really still worth mentioning, is stress in itself represents a risk factor. They did a study called the Inter-Heart Study in 2014 to look at stress. And stress is actually the 6th or 7th most important risk factor. So it's important to bring that out. But all other risk factors are pretty equal as far as how high the risk is. And they all need to be treated both as important and pretty much as equal.
And maybe the final question for this session is, what is the significance of my heart skipping a beat? That almost sounds like a Valentine's Day wish, but...
Yeah. So that's a good question. That often we don't really know. And that's why we do things like EKGs and heart monitors, because there's a lot of things that can cause you to feel like you're skipping a beat. This can just be an extra beat from the top part of the heart, an extra beat from the bottom part of the heart, or it could potentially be something more serious like atrial fibrillation. So I think it's a symptom to be aware of, and if it's something that's persistent, it certainly warrants an EKG, and probably would warrant a heart monitor at some point, so we can actually see what the electrical signal the heart is doing when that skip beat's occurring.
So there's a comment here that I'll tell you, Doctor, that says, thank you so very much, very helpful. I've been evaluated on medication, excellent information. So ladies and gentlemen, thank you, Dr. Peters, we really appreciate it. There were a number of questions that came in right at the end that we won't have time for today, but we will post the questions, we'll collect them and post the answers to these questions on the website within about 48 hours. And in that same time frame, you'll be able to review and see this entire presentation. And the website is there for you. It's ums.org/letstalk. So today's presentation will be there, as well as all of those which we've conducted since last June, and the topics are listed there at the bottom. In January, we last spoke about COVID-19 and vaccines, which is a very hot topic these days. Moving forward, next month, we will be talking about advanced directives, and these sessions are always the third Wednesday in the month. Next month will also be at noon. And again, any questions that we've collected today but not been able to address, we will put up on the website, and you will be able to see those together with these slides and this entire presentation. Thank you again, Dr. Peters, and thank you all for joining us this afternoon.